I've been using lasers and light-based devices since the mid-1980s, and we use a variety of different technologies. Today I'm going to talk a bit about my use of UltraPulse CO2 laser technology for treating scars and also for drug delivery. So because of our practice, which is a private practice in a community setting, we don't see a lot of big burn scars. Those are relegated to burn centers and to hospitals for the most part. We treat small scars, usually accidental scars, sometimes burn scars, sometimes surgically caused scars, often traumatic scars. We treat young scars, we treat old scars, we treat some keloids. For the most part, hypertrophic scars are the scars we like to treat because they respond the best, whether they're new or old. I think some of our colleagues shy away from older scars, and there's a belief in the community that if your scar is old, they're not going to respond, which of course is completely untrue. And so we treat all comers, whether they're new or old scars, and they do uniformly well. I think in general, if you treat a young scar, you're going to see earlier improvement, faster improvement, but I think in the end, even an old scar can achieve a beautiful result. Might take a few more treatments, be a bit more patient, but I see no reason why older scars should not be treated basically the same as young scars. There are lots of CO2 lasers. There are lots of fractional CO2 lasers on the market. It's my impression from my colleagues, specifically Dr. Ubelhauer from San Diego and Dr. Anderson in Boston, that the Deep FX, or sometimes called SCAR FX, which is a deeply penetrating fractional CO2 laser, may be the gold standard for treating scars. We have 5 different fractional CO2 lasers, which is probably unusual in the marketplace, but the one I use for my scars is the Deep FX, and the reason is small spot, deep penetrating, and because of the experience, which is global and large, it seems to me that the high energy ability, not necessarily using high energy, but the ability to drill tiny holes fractionally in the skin in a scar, which somehow changes the scar morphology and the scar biology and makes tight scars softer and helps contracted scars. That's the reason I choose to use the Deep FX over my other fractional CO2 lasers specifically for scars. So I think what's crucial, and the reason CW or continuous wave CO2 lasers are not traditionally used to treat these scars, is you're leaving behind a zone of thermal injury, which is the last thing you want to do in a scar, and perhaps why some scars are worsened by CO2 laser vaporization. So what's key with the Deep FX is you can deliver these tiny dwells in the skin, very deep, very sharply, with almost no thermal injury at the edge or the base to stimulate neocollagenesis, which perhaps could actually worsen the scar. I think that's the problem with some of the other CO2 laser technologies. You get a nice indent, or you get a nice depression, or a nice hole made in the skin, or a nice ablation, but you get with it thermal injury, which could actually aggravate the scar. I see mostly hypertrophic scars, and they're mostly simple hypertrophic non-contracted scars. We love to see is hypertrophic scars that are also contracted, because we not only help to flatten them, soften them, decrease the redness, but we also can improve the contracture, sometimes within a day or 2 of the procedure, which we still find striking and hard to explain, but it's real. Well, we often use a combination of lasers when treating scars. Frequently, our combination is pulsed dye laser followed by fractional ablative. Sometimes we do fractional non-ablative with pulse dye laser, but we often do the 2 on the same day. Almost always the pulse dye laser first before there's any laser-induced injury, followed by the CO2 laser, almost always in that order. Topical anesthetic first, pulse dye laser followed by the Deep FX. Sometimes deeper scars, or in someone very sensitive, we'll use intralesional anesthesia, but that's actually uncommon. The results have actually been striking in most individuals. We have flattened some scars totally, so all that's left is the pigmentary change that might have been there present before the treatment, so maybe some hypopigmentation. Sometimes you cannot see the scar at all, but that's uncommon. Sometimes the scar flattens somewhat, but not totally. Sometimes the red component goes away first, but the goal is to improve the redness if there's red, improve the overall texture, soften the scar if we can, and also improve contracture. In general, keloids, which are not uncommon, unfortunately, are very difficult to treat. And lasers don't have a major role in the treatment of keloids, at least today, maybe someday in the future. While the fractional ablative lasers help hypertrophic scars, they've not been shown to be particularly effective in keloids. And the key is to remember, these are active growing scars, and any trauma can actually make them worse. So it's important to be gentle and treat them with respect. We sometimes use pulsed dye laser to treat keloids. We often do intralesional injections of steroids. We occasionally use surgery, but rarely because of the risk of making them worse. So in general, in 2016, they are very difficult to treat, one of the hardest things we treat in practice. Well, keloids are very common in certain ethnic groups and also certain locations. Chest and back, very, very common. African Americans, people from Africa. Some other ethnic groups have slightly higher predilection for keloids. In a nutshell, avoid trauma in these patients. If they have acne-induced scars, get the acne under control, because every time they get an acne cyst, they often end up with a keloid, and treat aggressively and often, but by aggressively, I mean intralesional injections with Canalog, sometimes pulsed dye laser, avoid ablative technology for now. So it turns out that laser-assisted drug delivery is one of the hottest topics in skin medicine and dermatology in general. This past year at ASLMS, there was an entire course dedicated to delivery of drugs through the enhancement by lasers. And my take-home information from that is, number one, fractional ablative is probably better than fractional non-ablative, that you actually need a hole so the drug can penetrate, that these holes actually stay open longer than initially anticipated. It's not a matter of seconds or minutes, it's actually approaching 90 minutes, so there's no rush after making the little holes with, say, the Deep FX to put on the drug. And the question really is, what drugs should be used and what should be avoided? Analgesia, absolutely. Anesthetic, perhaps, and why not? PDT drugs, so ALA and MAL-PDT, there are some beautiful studies that have been shown to enhance the uptake and, in fact, the outcomes when used in combination with light therapy afterwards. Methotrexate theoretically could go down these holes. All kinds of cosmeceuticals, from vitamin C to tretinoin or vitamin A derivatives. The list is very long. The question is, how much drug? How often? How long after the holes are made? How big should the holes be? What laser is the best laser to use to do all this? We're at our infancy in this space, but it's a very exciting space, and it's actually moving ahead very, very quickly. I think it's a very exciting space to watch. We're not using it traditionally in many practices in 2016, but I would venture to guess in the next few years it will become part of our standard treatment for, say, ALA and MAL-PDT. It will probably be a standard for delivering topical anesthetic, and it may be a standard for delivering all kinds of drugs, which for now, we don't get into the skin particularly well. So for example, vitamin C, which we know can reverse sunburns, can actually reverse photoaging, has all kinds of biologic effects, but it's a drug that's hard to work with, it oxidizes quickly, hard to get into the skin. Why not make little holes, apply it, and enhance the delivery dramatically? So it's a very exciting area, and I'm looking forward to seeing what happens.